Good evening. Today we'll talk about what are the basically the topic is AK in pregnancy. From beginning, we'll see some what are the physiological changes in pregnancy in the renal systems and the renal adaptations in pregnancy. How the kidney get adapt to the pregnancy conditions. There is some anatomical changes and some physiological changes. In the anatomical changes, there will be 1 centimeter increase in the size of kidneys due to hypertrophy of glomeruli and dilatation of the proximal collecting systems. Ureter dilated due to pressure of the gravid uterus. What are the physiological changes? The first one, remember there is an increase in the renal plasma flow, that is 40 to 50%. That will be maximum at 16 weeks and maintained till 34 weeks. Then gradually the glomerular filtration rate, that renal plasma flow, it is decreased, falls by 25% after 34 weeks. And you can see the 50% the increase in the glomerular filtration rate increase because of increase in the renal plasma flow, that will lead to increased glomerular filtration rate, that will cause increased clearance of creatinine, urea and blood, urea nitrogen and uric acid from the maternal blood. In the anatomical changes, you can see there will be mostly the most of the anatomical changes will happen in the collecting system. There will be a dilatation of the ureter and pelvis, that is because of the relaxing effect of the progesterone on the smooth muscles. Also dilatation is more on the right side because the uterus is dextrorotated, and the dilatation upright ovarian venous plexus, remember very important things. Uterus is dextrorotations of the uterus and the dilatation of the right ovarian venous plexus, because the two things that will cause dilatation more on the right side. Then risk of urinastasis and UTI also increases in pregnancy. Okay. In physiological changes, there will be a renal vasodilatation in the pregnancy is due to what are the factors? Increase in diastolic renal factors, endothelial relaxing factor, nitric oxides, vasodilatory prostaglandins, relaxin, all increases renal plasma flow and glomerular filtration rates. Okay, because there will be vasodilatation that will cause increase in renal plasma flow, that will cause an glomerular filtration rate in so increase. The proteinuria in pregnancy is considered abnormal when it exceeds 300 mg per deciliter per day. And if it's a non-pregnant woman, the 150 mg per day has to be there. Okay, what are the renal physiology in pregnancy? First of all, you can see the hypothalamus has there will be a decreased threshold for the release of adrenal catecholaminergic hormones, that is vasopressin release. That will cause because of the decreased threshold for vasopressin release, and systemic changes will happen, decreased sensitivity to renin angiotensin aldosterone activity system, that will cause us increased urinary water retention and in decreased plasma osmolality, because RAS has the basic functions to maintain the plasma osmolality, and it will cause increased excretion of the water, there will be less chance of water retention. So because of all this decreased threshold of vasopressin release, decreased sensitivity to RAS activity, that will cause water retentions and increase plasma osmolality. Then renal hemodynamic step, what are the endocrine functions? Because of increased erythropoietin activity, increased RAS activities, um, there will be cause tubular functions, glycoside increase glucose secretions in the urines, because decrease absorptions, because decrease in the renal thresholds, calcium excretion also happen, like include glycosaminoglycan. Okay. Then renal hemodialysis, there will increase in 50 to 85% of increased renal blood flow, 50% increase GFR, afferent arterial vasodilatation, because of relaxin and progesterone and nitric oxide, because these two are released by the corpus luteum in the pregnancy. The structural changes, the pelvic axial system dilatations happen, hydronephrosis happen, increased GBM pore size contribute to the physiological proteinuria, because GBM pore size will be increased in the pregnancy, that will cause proteinuria and the pelvic axial system dilatations. Okay, remember, basically you have to discuss the total 5 renal disorders. First is urinary tract infections, acute renal failures, AKI, that is chronic renal disease, glomerulopathies, pregnancy in renal transplant recipient. So basically we are focusing in the ACI in the pregnancy. So have a case study. Mr. A came to emergency with history of home delivery, 3 hours is ego for in placenta, heavy bleedings for vagina. On examination, pulse 120, BP was she was in shock, pallor was plus. On catheterization, 30 high color urines came, all her clots soaked with blood. Okay. Then we have managed the patients with casualty. A 20-gram IV canal was secured, NS fluid was started, 2 unit blood rinse, placenta was lying in the vagina, was removed. Then PPS management is done, bleeding was controlled, patient shifted to ward. Then day 2 urine output has decreased to less than 400 in 24 hours, creatinine is an increasing trend. So patients sent for hemodialysis because of high potassium level and metabolic acidemia. Okay. So here the because of prerenal AKI, because of postpartum hemorrhage, that will cause a decrease in renal perfusion, that will cause AKI in the pregnancy. So pregnancy related acute kidney injury, you also can term as a brachy. So basically the cause is abrupt loss of kidney functions due to the pregnancy, labor and delivery are the or the postpartum period. The consensus definition, we have a variety of definition for acute kidney injury. There is a rifle criteria, there is a acute criteria, there is a KidGo criteria, and we don't have any no classification is specific for pregnancy. So incidence is rare in pregnancy, that is AK in pregnancy is very rare, that is 0.05%. But now there is increase is maternal fetal complication with high mortality rate. We have a KidGo guideline that define AKIs, that is increased serum creatinine is more than equal to 0.3 mg per deciliter within 48 hours, or increased serum creatinine more than equal to 1.5 times baseline, which is known which has been done prior 7 days before, or urine volume suddenly dropped to within 6 hours if it is less than 0.5 ml per kg per hours. Suppose it's a 60 kg body weight patients into 0.5, that is 300 ml over 6 hours, it causes acute kidney injury. Okay. So AKI stays has been severity has been okay. The AKI stays for severity according to the following criteria. Stage 1 is the 1.5 to 1.9 time baseline, or more than equal to 0.3 milligram per deciliter absolute increase in serum creatinine value. If you see urine volume is less than 0.5 ml per kg per hour over 6 to 12 hours. Then stage 2 is the creatinine value has to be increased 2 to 2.9 times, more than 2 to 2.9 times baseline, and the urine volume is less than 0.5 per ml kg per hours of more than 12 hours. Okay. Then stage 3 is more serum creatinine is more than 3 times from baselines, or increased serum creatinine absolute value is more than 4 milligram per deciliter, or in patient initiation who have already started renal replacement therapy, or if a patient is less than 18 years, there will be a decrease in the effective GFR, that is less than 35 ml per minute for body surface area, or if you take an urine volume count less than 0.3 ml per kg per hours for more than 24 hours, more than equal to, or anuria for more than 12 hours. Okay. What are the causes of acute kidney injury in the pregnancy? The most common cause is the preeclampsia related syndrome, that is the most common cause. Then obstetric hemorrhage, early pregnancy hemorrhage, abruptions, ectopic pregnancy, antepartum hemorrhage, especially abruptions, PPS, DIC, and the infection like septic abortion, chorioamnionitis, puerperal sepsis, septic shock, drugs induced, especially NSAID induced. Then dehydration, hyperemesis gravidarum can cause dehydration, that is cause prerenal AKI, renal diseases, post-renal obstructive uropathy, amniotic fluid embolism, acute fatty liver of pregnancy, hemolytic urine syndrome, thrombocytopenic purpura, post-operative oliguria, idiopathic postpartum AKI. These are the conditions already I discussed. Pre-renal conditions, renal, post-renal, and interrenal. Pre-renal, already you know the pregnancy-related condition like hyperemesis gravidarum, vomiting in pregnancy, HELP syndrome, AFLP, uterine hemorrhage, pregnancy-unrelated causes like vomiting due to UTI, other infections, congestive heart failure, diuretic uses. Post-renal pregnancy-related causes like bilateral hydronephrosis due to trauma to the ureter during the cesarean sections, pregnancy unrelated condition like bilateral renal ureter obstructions due to stones, ureteral obstructions due to crystalluria, bladder outlet obstructions, Internal causes like pregnancy related, you can see acute renal necrosis, acute cortical necrosis, preeclampsia, HELLP syndrome, AFLP, amyloid embolism. These both are in the pre-renal and the renal causes. Pulmonary embolism, thrombotic microangiopathy, hemolytic anemia, worsening of existing glomerular diseases like pregnancy unrelated condition, acute tubular necrosis, glomerular diseases, acute interstitial nephritis. Okay. What are the pathophysiology of AKI? There is a two pathology. One is acute tubular necrosis. One is acute cortical necrosis. Acute tubular necrosis. Tubule is more necrosis in hypovolemic state. Preeclampsia HELLP syndrome. The causes of acute cortical necrosis will happen: abruptions, septic abortions, and disseminated intravascular coagulation, hematuria, and the anuria is the causes. The ATN is less serious compared to the bilateral cortical necrosis. Is high mortality and it will be ATN is reversible. Commonly, the causes are like sepsis, hypertension, AFLP, hyperemesis, nephrotoxic dog, cause of acute tubular necrosis. But 50 to 30% of all brachy complicate with BRC, bilateral renal cortical necrosis. The kidney lesions here in ATN is focal, that is the most characteristic, but in cortical necrosis it can be focal, it can be patchy, it can be confluent, or it can be gross because of thrombosis of the segment of the renal vascular system. ATN dilatation, it causes dilatation and flattening of the epithelium of the distal convoluted tubule. And cortical necrosis is irreversible due to prolonged vasospasm that occur in IUFD, eclampsia, preeclampsia, and HELLP syndrome, AFLP. Presence of pigmented cast in distal part of nephron seen in acute tubular necrosis, and the cortical necrosis that lead to oliguria can lead to anuria, azotemia, and conjunctive coagulopathy. Most respond to the ATN mostly respond to the fluid management, volume restriction, rigorous antibiotics, but also cortical necrosis also had extrarenal manifestation like cardiac dilatations, congestive heart failure, lethargy, and convulsions. The phases of acute renal failure, that will be a incipient phase where the marked decrease in urine output. Okay, let's tackle the four phases of acute renal failure. There will be an incipient phase, there will be a marked decrease in urine output. Then phase of anuria, that is urine output less than 100 ml in 24 hours. Initially, patient looks well, but gradually deteriorate. Leukocytosis, protein bearing amount, presence of red cell cast, suggestive glomerulopathies. ECG, you can see the absent PUF, prolonged QRS complex, peak TUFs. How to differentiate pre-renal AKI versus renal AKI? Very, very important points. Pre-renal AKI, there will be because of pre-renal AKI, there is tube is fine, everything is fine. So urinary sodium excretion is normal, so less than 20 millicule per liters. If it is renal, there is a tubular readjustment is defect. The more sodium will come into the urine, 40 per liter. Urine osmolality, because pre-renal AKI, there will be a hypo dehydration, so osmolality will be increased more than 500, and renal there is less than 350. Fractional is less than 1% in pre-renal and more than 2% in renal. Phase of diuresis, early diuresis, there will be a serum creatinine, blood urine nitrogen, sodium potassium are raised. Late diuresis causes like osmotic diuresis due to high blood urea. Fractional inadequacy of tubular readjustations, release of surplus fluid electrolyte, especially sodium and potassium. Phase of recovery, tubular epithelial region function reactively make about 1 year to full recovery. Then, what are the specific investigation you should send for urine analysis? Pre-renal disease, normal, contain Highland cast. For acute tubular necrosis, there will be a muddy brown cast. Renal tubular epithelial cells secondary to the sloughing of the tubular cells into the lumina due to ischemia and toxic injury. Urine culture, you can send. Urine sodium, you can see pre-renal renal AKI. Acute tubular necrosis more than 40 milliequivalent per liters, less than 20 if it is pre-renal causes. CVC, blood smear to evaluate microangiopathy, hemolysis, thrombocytopenia, bilirubin concentration, aptoglobin LDS due to rule out hemolysis, AST, LT, and C3, C4, ANCA, ANNA, ANA, and renal ultrasounds. Stabilize. What are the how to principle of the management of acute renal failure patients? Stabilize the patient, ABC. Prevent further kidney damage. Treatment of the pathology. Maintain the supportive care. Fetal monitoring and planning delivery when indicated. Timely institution of renal replacement therapy. First, correct pre-renal and post-renal causes. Search for evidence of ischemic nephrotoxic or renal parenchymal disease. In 18 patients, if patient is volume overloaded, so in volume overloaded patients, you should give high dose furosemide, IV 20 times the serum creatinine value. can be given. In patients who are not volume overloaded, then you should give volume fluid management 500 to 1000 ml normal saline over 30 to 60 minutes. Conservative therapy, urine catheter to accurately retain urine output. However, it should not be kept for a longer time due to risk of UTI. Strict intake output chart should be maintained. Daily weight measurement should be done. Okay. Then limit fluids to 500 ml to previous daily losses. Avoid nephrotoxic drug, treat hyperkalemia and the acidosis. Dialysis for volume overload, pericarditis, and GI bleeding due to uremic gastritis. Symptoms severe of symptomatic uremia, severe acidosis. You can go for dialysis. Pigment-induced renal injuries during hemolysis, rhabdomyolysis is treated with alkalinization urine. If urine output improve after the bolus dose of furosemide, it can be given as IV infusion 20 mg per hour or repeated bolus every 6 hourly. Addition of thiazide diuretic enhances diuresis in response patients. Abdominal compartment syndrome causes renal failure as a result of abdominal fluid accumulations following trauma, surgery, massive ascites. Intra-abdominal pressure more than 25 mg can be cured by abdominal decompressions. Then acetylcysteine 600 mg per oral BD for 4 days. Reduce the incidence of contrast nephropathy. Start 1 day prior procedures. Aminoglycoside induced AKI, no, usually it is non-oligonucleotide. So, and avoid using it in elderly patients. Patients with hepatic or renal dysfunction. So, avoid aminoglycoside. Limit the duration therapy less than 5 to 10 days. 2 to 3 ample and sodium bicarbonate in 1 liter 5% dextrose. IV infusion to use to alkaline the urine. In pigment-induced renal injury, Rasburicase 15 mg per kg IV infusion effective in acute uric acid nephropathy, tumor lysis syndrome. Prednisone 60 mg per hour daily is advocate to hasten recovery in drug-induced acute interstitial nephritis. In women with severe preeclampsia, if a creatinine is more than 1.36 mg per deciliter, fluid replacement should be judiciously monitored depending on the pulmonary arterial catheter finding. Usually, the central venous pressure line may be inaccurate in preeclampsia patient due to increased system-vascular resistance. Hemodynamic parameters: if it is low pulmonary capillary wedge pressure and high system-vascular resistance, then you should go for a fluid therapy 250 ml per hour till pulmonary capillary wedge pressure is 10 to 12 mm Hg. If normal elevated and normal system-vascular resistance, so you can go for IV agents, low dopamine. Marked elevated PCWP and high system vascularity, aggressive reductions of afterload with diuretics, furosemide 5 mg per hour, fluid restrictions has to be done. Once the patient become euvolemic, you should stop. IV fluid should be transfused equal to the previous previous our urine output plus previous A plus insensible loss has to be calculated. It can be if the patient is taken orally, so start orally. Fluids replacement should be include. You can give blood or any isotonic solutions. Dextrose solutions hypotonic that can lead to maternal hypertension, which is colloid also can increase pulmonary capillary vice pressure. So avoid in preeclampsia patients. Colloid should be avoided in preeclampsia. Indication: dialysis in pregnancy, electrolyte abnormality refracted to the medical treatments, volume overload with that will cause congestive failure, pulmonary edema refracted to standard therapy, severe metabolic acidosis, uremia, blood urinary nitrogen more than 30 mg per deciliter, and serum creatinine more than 5.6 mg per deciliter. Other causes management. Causes of acute renal failure in the pregnancy: post-operative oliguria, obstetric uropathy use due to nephrotoxic dose, use and necropathic dose should be excluded. Adequate volume. Post-operative oliguria should rule out all these obstetric uropathy and nephrotoxic drugs. Adequate volume and electrolyte replacement should be corrected. TTP to be differentiated from preeclampsia using biochemical test. Mild cases you can go plasma infusions. Severe case plasmapheresis. You can give TTP aspirin along with plasmapheresis. Immunosuppressive prednisone cyclophosphamide. Splenectomy may be considered non-responding patient. Delivery at 34 weeks should be done. Hemolytic uremic syndrome, dialysis required serially, usually, and severe anemia, there is chance of transfusion. Plasma excess and prednisone to be continued even postpartum for 1 month. Delivery advice once diagnosis is confirmed. Acute fatty liver pregnancy, ICU management with intensive monitoring. Coagulopathy, hypoglycemia should be monitored. Fluid balance should be corrected. First followed by delivery attempt after establishing method. Temporary dialysis in few cases. Urinary tract obstruction, ureteric stent put kept for 1 month. Temporary nephrostomy if stenting failed. What are the preventive and future outcome? AKI may be prevented. Prompt vigorous volume replacement which crystallized and blood in case of massive hemorrhage. Delivery in pregnancy complicated with severe preeclampsia, eclampsia, careful blood transfusion if blood loss more than average. You should go for close observation for early sign of sepsis, shock in women with pyelonephritis, septic abortion, choreo and pelvic infections. avoiding loop directed to the oliguria before ensuring that blood pressure and blood volume cardiac output should be adequate for renal functions. Judicious use of vasoconstrictor to treat hypertension and only after it has been determined the pathological cause is vasodilatations. Future outcome, even though renal functions recover in 1 year or so, women in subsequent pregnancy have higher incidence of hypertension and adverse outcomes.